I asked Dr. Francisco Ruiz from Chile to speak about management of distal biceps pathology.
Thank you very much, Professor Monteira, Professor Itoi. On behalf of Chilean Shoulder and Elbow Society, I bring all my greetings. Regarding anatomy in the distal biceps lesions, you must remember the distal insertion. Last year's papers show us that this is not a single tendon, that we should think about it in a short head and a long head. This short head has its insertion distally than the long head, and especially this short head will help in neutral and in pronation having the maximal flexion, and at the difference that the long head will help in full supination. At the other hand, we must remember the presence of the bicipital aponeurosis called the lacertus fibrosus. It has double way of working. One of them is helping the vector of force of the distal biceps that moving from the radius to the ulna, and the other way protecting the neurovascular bundle. We all know the function of the distal, of the biceps as a powerful supinator, having the forearm in 90% in 90 degrees flexion, as well as a secondary forearm flexure at the maximal forearm supination. Usually these lesions are around in a man between 30 and 60 years old in the dominant side, usually around people taking tobacco and steroids. It is around 3% of the tendon ruptures, the most frequent tendon rupture around the elbow. And as a matter of the lesion of the mechanisms, they are well known. Some of them, a sudden extension having the forearm and the elbow at a 90 degrees flexion and a supination. In weightlifting activities, some of them are violent movements or accidents. And usually we have an avulsion at the radial tuberosity. The myotendinous rupture, they are present, but they are not very frequent. And as a pathogenesis, we know that we have different causes of this. Some of them as the tendinosis, the degenerative changes, the vascular changes with the hypovascular region. We must remember that the last 2 centimeters of the distal biceps tendons, it has a not very good vascular. And finally, the mechanical theory. You must remember that the space between the radius and the ulna, it decreases 50% when we move from supination to pronation. And on the other hand, if we remember that this tendon occupies around 85% of this space, you should imagine what happens. This is a diagram where we can see that this space is very narrow. If we go from pronation to supination, it goes even narrower. And almost all this space is occupied by the distal tendon. And if we think in one hand, if the space is decreasing, and the other hand, the presence of some osteophytes that can be dot or lined. So the clinical presentation is very well known. Active middle-aged men, they feel a sudden pop in the antecubital fossa. The mechanism we already talked about it. There has some ecchymosis, mild pain, and mainly supination weakness. When we are taking examination of these patients, sometimes we can observe this invert Popeye sign, but it's not all the times present. And the explanation of this is the presence of the lacertus fibrosus. If it is intact, it will be difficult to find this. And the other way, some of these lesions are partial lesions. So in partial lesions, almost all the times, we will not be able to find this Popeye inverted sign. And that's why O'Driscoll taught us this sign that is very helpful. It's the O'Driscoll hook test, and we can do it having the forearm in full supination, in flexion, 90 degrees, and with our fingers, we go from lateral to medium, trying to grab this cord-like structure, and this side we can see it, we can feel it, and this side we don't have it. So when the hook test is positive, this cord-like structure is not there. But sometimes we feel it, but with pain. So in that cases, we should think about partial tears. So a partial tear, it has a hook negative, but with pain. X-rays, usually they are not very helpful, with the only exception that sometimes that it's not very frequent. We can see some avulsions, but they are very infrequent. Ultrasonography is very dependent on the operator, but on the other side, sometimes it can help us to differentiate between total and partial tears. Maybe in MRI we are being more lucky. We were able to see the rupture, especially the total ruptures. We have a sensitivity around 100% if the rupture is complete, but unfortunately the sensitivity is not very good when the tears are partial. So as a matter of making some type of classification, we can think about that we have partial or complete. We can't forget about the structure of the lacertus. We can think between acute or chronic, and maybe we could talk about that later, when we can call them acute or chronic, maybe around 4 weeks. And on the other hand, if we would like to make some classifications regarding the type, we can think in insertional, the most frequent, and the myotendinous, the most infrequent. We know that if we would like to treat these patients with non-surgical treatment, we will have almost all the times a decrease in the supination strength going up to 40% and in some series even to 60%, that we should find decrease as well in flexion strength, that there will be weakness in weightlifting activities as well as supination activities. These patients, if we would like to treatment without surgery, most of the times they will not have any cramps. And this is special, because if we take a look to this, there are some publications telling us that some of these patients are able to come back to their activities without restrictions. But maybe the only explanation of having no restrictions is that these patients were not back again to full supination activities, like using a screwdriver, a hammer, or a baseball bat. So maybe the correct word here is adaptations. Maybe some of these patients, or almost all of them, if they're able to come back to the labor activities, adaptation must be the right word. So when will be the correct time to plan a surgery? For the last 15 years, we have heard a lot about it, but maybe sometimes they told us it's better to do a surgery before 10 days because the complications, they can rise even to double. In some others, before 2 weeks, because the complications were raised between 20 and 40%. And in these last publications, that the complications before 4 weeks, they're only 6%, and they can raise almost double. They have all in common that if you wait a longer time, the surgery will be more difficult, and the complications will raise. In any of all the studies, they raise almost to the double. You can choose from a single approach or a double. I usually do the single. And you can choose from any of these fixation devices: transosseous sutures, suture anchors, interferential screws, or cortical buttons. Here are some of them. The single incision, you most know about it. You can do suture anchors, 1 or 2. All of the studies are done with 2 anchors. Or this device, that is an extra medullary cortical button associated with an interferential screw. The other way, if you can choose it with a double incision, as Mayo surgeons do it, this is the technique that you can use transosseous sutures, putting the distal biceps tendon inside a groove, or you can use it with anchors. A lot of studies has been done trying to make a comparison between the different fixation devices, and all of them, they're similar. So there's no big difference trying to use an interferential screw, a cortical button, or suture anchors. The only thing that I think that you must take care about it is using these bioabsorbable interferential screws. There's described some osteolysis around them in almost all of the cases. So if you are trying to use an interferential screw, it's better to use a PIC one. About complications, I always told my patients that the complications are not very frequent, but when they happen, they are not very nice. We have to talk about the posterior interosseous nerve paralysis, the heteropic ossifications, the synostosis that are very infrequent, but sometimes they happen, and the re-ruptures. Maybe one of the explanations having the posterior interosseous nerve complications due to retractors, especially when you're using the single incisions. You have to take care when you put your homage retractors. The hematoma may be one of the other explanations regarding the complication with the interosseous nerve paralysis. As well as if you're planning to do a single incision, you're working just from the front and trying to make a dissection of the bicipital tuberosity. Sometimes you can't make sometimes of lesions of this nerve. This is nice, and that's why I put it over here, just in the bottom line. Some studies have been done that sometimes an hyperpression of the interosseous posterior nerve can be done at the arcade of Ruiz, and it happens usually when, here you can see the arcade and the nerve. And the theory, it says that during the hyperpronation of the forearm, especially when you're doing a double approach technique with flexion and extension that you needed, for having the bicipital tuberosity preparation, the posterior interosseous nerve will be trapped against the arcade of Ruiz, and that's why they made this study with a Swan's-Ganz catheter, and they showed that it doesn't matter if you're having your forearm or the elbow in flexion or in extension. When you have in full pronation, the nerve will be attached to the arcade of Ruiz. So maybe this is one of the explanations of the paralysis of the posterior interosseous nerve. The other complications, the heteropic ossifications, they are frequent. In our hands, we use usually indomethacins, 25 milligrams 3 times a day for 21 days. We have been very fortunate, but we have seen only very tiny of them. As well, when we do the preparation of the tunnels, we avoid the osseous debris. Regarding some of the last complications, the synostosis, this happens usually when you're planning to do a double approach. So you have to be very careful when you're doing the tunnel. You have to avoid the ulna. So you have to go against the extensors and the supinators. This way you can avoid having synostosis. This is a very nice paper of Ruiz that makes a comparison between single and double incision techniques. They showed us 90 patients, 48 of the patients, they underwent a single approach with suture anchors, and 42 of these patients underwent a double approach with transosseous sutures. They made a follow-up almost to 2 years with the DASH and ASIS elbow score. And what did they find? That the final isometric strengths, they had no difference at supination. Maybe they have a superior flexion in the double incision. And this is important, that the almost all of the posterior interosseous nerve paralysis, they were transient, very early, and usually they happen in the single incision and not in the double, as well as the paresthesias of the lateral antebrachiocutaneous nerve, usually seen in the anterior because of the use of the retractors. In our experience, we presented last year in Nagoya, we present our 21 patients, almost all of them were male, and we do for all of them a single incision using the R3X device. This is it's a mix of an extra medullary cortical button associated with a PIC interferential screw. Almost all of you know it. We prepare the distal tendon, we put the cortical button, and finally we put this PIC interferential screw. These are some of the images of the surgery. We take a look where the bicipital tuberosity is by intensific. We do the groove, and then we put it on the interference screw. We check finally if the cortical bottom is well located at the other side of the radius. This is the patient 1 year after surgery, and the hook test is now negative. Almost all of our patients were done with this single incision. Having this strong fixation allow us to have a very fast rehabilitation. We gave almost, this is in Spanish, we give all our patients this guide with all the activities that they were allowed up to 3 months. As a matter of summary, I would like to say that clinical findings are better than images. We should take care looking at our patient, touching it. I think that our Distal hook test is very easy, and it gives us a very good orientation about our lesion. On the other hand, the supination weakness happens, but almost all of the times they are not very symptomatic. Only some of them are symptomatic. We know that the surgery increases the strength. Unfortunately, this strength in flexion is very good, but in supination is not very good. In our hands, we have not made isocinetic exams. We just do the manual exam, and our patients, almost all of them, they were very happy after a single incision and using these devices. But I think there is space to make the isocinetic studies. There are small amount of complications, but you must tell of the patient that the complications, if they are very infrequent, they are important. There is no difference between the single and the double incision, as well that there is no difference in the fixation that you choose to use. The delayed surgery can increase complications, not the results. They will get better, but you must remember that if you do the surgery after 2, 3, or even 4 weeks, the complications can raise even to the double. And about the fixation angle, nowadays it's more ominous than the fixation angle. You can do the fixation angle between 70 to 90 degrees. In my hands, it's very difficult. So usually that's why I try to do the surgery very early to avoid this. The studies that say that you are able to do a fixation angle up to 100, almost all of them were with this double incision, because trying to make a fixation with a single incision at 90 degrees of the shoulder, of the elbow, is almost impossible. And the use of the endomethacin, in our hands it works. There is no evidence yet. And in the last images I want to show this, the anatomy helps the biomechanics. Certainly, we have to take care about that. Especially if we are using a single anterior approach, it's very difficult to approach. This is the normal anatomic position of the distal biceps tendon. This is the position that almost all the surgeons do it when they use a single anterior approach. So if you're trying to go from this to this, you must do a lot of supination. Almost all of the time it's not very easy, and why not impossible. So if you want to have a very good supination force, you must try to put from here to here. So think about it. If you're not able through an anterior incision, even at maximum supination, think about going to a posterior incision, a double incision. And regarding the fixation, usually I use this extra medullary fixation, not this one. This one, I think, is less invasive. It has less chances of having a fracture of the proximal radius. And the biomechanics studies has shown us that you don't need to have the distal tendon be put in a socket. It will heal here, and maybe the vector for supinations will be better. Thank you.